Hi, my name is Dr. Ashley Brockbaca, the Trauma Responsive Service Array Developer at the Colorado Office of Behavioral Health. The State Innovation Model, or SIM grant, is one of the preeminent examples of what innovation can look like in the state of Colorado. SIM is a $65 million grant from the Centers for Medicare and Medicaid Services to help primary care practices integrate behavioral health and primary care across the state. This whole patient care model is pushing the boundaries of what we can expect for integrated care delivery throughout the state. The Colorado Office of Behavioral Health, in collaboration with SIM, has developed this video to examine the value and importance of having primary care and behavioral health team members address trauma-related health issues during a patient encounter. To begin with, how is trauma defined? We often think of trauma as an event in our lives that has threatened our safety or even caused injury. But we have a tendency to focus on the event. However, trauma is not really the event itself. It's the person's unique feelings in response to an event, such as violence, or enduring conditions, such as chronic abuse or homelessness, that threaten their safety or the safety of a loved one. And the feelings can linger, often years after the event happened. The emotions can lead to physiological changes and maladaptive coping mechanisms, like using drugs, which compromise a patient's well-being.
Trauma, I think, is like an uninvited guest into our lives. It's a guest that is there, but we often don't even know it's there. And so the patients aren't aware that it's affecting their health, the doctor's not aware, the counselor's not aware. And if we don't ask about it specifically, it kind of remains unknown and untreatable.
It's very easy in the busyness of a clinic day in a family medicine clinic to miss trauma. Unfortunately, I and probably many other primary care doctors forget to think about it until we run into an issue that isn't getting better. That forces us to stop and think, what else is going on here? And that's when we start asking questions about trauma.
What's the kindest, lowest energy way that you can ask about trauma? Saying to the child, have you been traumatized, is not likely to get you anywhere. But if you ask instead something to the effect of, sometimes bad things, scary things can happen to people. They can happen to you, or they might have happened to somebody that you cared about. And sometimes it's hard to stop thinking about it. Has that ever happened to you?
As a residency who trains young family doctors and also medical family therapy fellows, we train them all in trauma. It's a core part of our curriculum. We do lots of training in the adverse childhood experiences. We teach them how to use the screener for ACEs. We teach them about how the science behind having these experiences as a child will impact their health as an adult.
Some patients who experience trauma-related anxiety will display signs of hyperarousal, including physical symptoms such as a faster heart rate and shallow, rapid breathing, or changes in behavior. Other people exhibit hypoarousal, where they kind of shut down and become depressed in response to trauma.
Really, it's a symptom of something, and it's getting at whatever that something is that we need to be aware of as physicians. And trauma oftentimes can be the cause of that hyperarousal. So what does hyperarousal look like? Well, before the patient even gets to the clinic, that could look like your patient calling all the time and very concerned and worried about being able to make their appointment, getting their medications on time. Hyperarousal could look like a patient who's on your schedule for insomnia because they're having a hard time sleeping, or anxiety in general. I see hyperarousal as the patient who is showing up 30 minutes early to their appointment and wanting to be seen by myself before they were scheduled to see an appointment.
It's important to remember that traumatic responses are initially adaptive and they exist for a reason. In the moment of danger, these fear responses are protective. But it's when the fear becomes chronic or repeated, or to an extent that the person is overwhelmed, that the responses become maladaptive.
Some of the long-term health risks of trauma are related to those changes in their behaviors and their choices for coping. And so a person who's home a lot might not exercise anymore. She might choose unhealthy foods to help give her some comfort. She might choose alcohol. And so pretty soon she's going to have early signs of obesity and then prediabetes. When her heart's always keyed up, that's going to lead to long-term heart risks. And so all these things become connected into a big web that extends well beyond the initial trauma.
Medical interventions are going to have minimal results if underlying emotional and behavioral health issues are not addressed. It's the difference between treating the cause of the problem or only treating the symptoms. When you are working with a patient to make lifestyle changes, their risky health behaviors, like smoking or overeating, may be coping mechanisms, and we can't expect them to give up their coping mechanisms without addressing their underlying trauma. One of the keys to identifying trauma-related health issues is a whole patient history. The patient's life history is just as important as their medical history. When a provider opens up a patient's life history, connections to a patient's symptoms can be seen that would otherwise not appear. The whole patient history can indicate to the medical provider that a patient's symptoms of cardiovascular disease or diabetes or ADHD may be a manifestation of trauma. A whole patient history is part of your medical team process. What does your patient intake look like? Where in your practice are you accounting for the whole patient life history? Whose role is it to take the whole patient history? When a flag is raised, what is your integrated team plan?
Really, we need a team to be able to address this and have our behavioral health colleagues work with us to do therapy, to help them identify, accept what's happened in their life, but be able to live their life despite that.
In our clinic, we try to do a trauma-informed care from the front desk, being trained in how to welcome people, help them to feel at home in our clinic, how to respond to them when they are showing signs of hyperarousal or not feeling safe, to our nurses asking before they do an exam, before they take a patient's vitals, explaining what they're doing and why they're doing it so the patient feels like they're not being taken advantage of, so they're not reacting to us. And then our doctors are trained to have trauma kind of always in the middle of their differential diagnosis. And trauma history, for me, often starts off with a simple question of, have you had any experiences like that in your life that keep coming back into your life and preventing you from having the life you want to have? And so that's kind of a nice opening question. If they don't have anything that seems relevant to them, I might ask a follow-up question about, have you ever had experience with physical abuse or neglect or sexual abuse or emotional abuse? Or have you had experiences from your childhood that are still unsettling to you? Focusing more on the relationship and having the relationship always be the core, that above all else, my job today is to have a relationship with this patient and to help them feel safe so that they can open up over time.
Vicarious trauma is important to identify in the integrated healthcare setting. The people who work closely with patients experience this secondary traumatic stress as part of the job. Similar to this are compassion fatigue, burnout, and moral distress, when policies or routines conflict with beliefs about patient care. Secondary traumatic stress can affect anyone on the care team, from physicians to the front desk staff. It's essential to address the secondary traumatic stress and build resiliency within your care team. When you work with patients who are struggling in any way, whether it's due to medical or grief or trauma, this can have an impact on the providers. Building provider resiliency will enable better patient care.
We see horrible things happen. We see unfair things happen. And so it's important that as a team, as a physician and as a member of a team, and for members of my team, that we have time to talk about this and that we have time to process that, just like the person who experienced the trauma. I think this is one of the important roles of having huddles before you see patients, so that each member of the team can talk about how they've interacted with that patient and what they've seen, because it gives them that opportunity to then let go of this or make it public knowledge. But as important as that is, it's very important to have a team debriefing.
Trauma is an underlying cause of many different mental and physical health symptoms. But when we diagnose based on symptoms alone, we may miss the underlying causes, and we can unfortunately do harm. Like the blind men examining the elephant, we need to see the big picture and avoid focusing on symptoms in isolation. If a child is diagnosed with ODD or conduct disorder when really it's trauma, that child's life trajectory will be headed toward the juvenile justice system or the criminal justice system. A child that is put on ADHD medication who also has a history of trauma will benefit less from the medication than a child without the trauma history. But if we understand that it's trauma, there is the potential for real healing, and we can avoid resorting to symptom management.
The misdiagnosis of trauma as something else can definitely have real consequences for the patient. For instance, if a child's erratic behavior is being conceptualized as oppositional defiant, well, this kid's just, he's oppositional. He's refusing to follow directions, is causing problems at school, just won't get along with anybody, and is fighting with parents. If that's being conceptualized as this is a kid that just doesn't want to listen to authority figures, rather than actually was quite an agreeable child until severely traumatized, you can imagine that the adult approach to that would be markedly different, because if the adults are conceptualizing this as we need to set firmer limits and we need to basically corral you into doing what you need to do, we need to sort of make the behavior stop, that's very different than you are actually reacting to something quite serious that's terrorizing you in your own mind.
Trauma-informed care means interacting with all patients in a caring way that avoids re-traumatizing them. It also means responding to individualized patient needs. Trauma can manifest itself very differently in different people, so there are no one-size-fits-all interventions. But for most people with a trauma history, one of the most healing experiences they can have is to have other people be attuned to their emotional needs. Anyone on the care team can do that. Even if you're not a therapist, your interactions with a patient can be therapeutic, and you can put a patient on the path to healing. It can take time to address trauma-related needs, but trauma is something you can heal from, and it's worth it.